Good afternoon. My name's Lenel James with Blue Cross Blue Shield Association. I'm part of the Da Vinci Project.
Hi everyone, I'm Karuna Relwani, also from Blue Cross Blue Shield Association, and we're excited to tell you about the Da Vinci Project today.
So today's going to be a 101, so this is not going to be a very deep dive. Uh, However, if you get real interested in wanting to know more about any of the slides we cover at a high level, we've got the HL7 kiosk, we've got the FHIR at Scale kiosk, we've got the Da Vinci kiosk, where you can go at a much deeper level because there's a lot more slides than we're covering. Because we're going to do this in about 25 to 30 minutes. We're going to leave some time for some questions and really give you a flavor for the history of Da Vinci and why we're doing it, how we're doing it, and also give you a taste of some of the depth of the detail. One of the things we start with at all the meetings we do is the antitrust policy because the Da Vinci Project includes a variety of members that are competitors. Well, one of my colleagues from Cigna Evernorth did the term co-opetition. So we cooperate to build the standards, and then we go out in the field and compete against each other with the standards that we built. And so we start almost all the HL7 meetings making sure everybody knows, to make sure we don't get into any discussions of pricing or strategy. We're talking about the terminology and the standards and the use cases as part of this work. It's a multi-stakeholder collaborative. We've been going at this for over 6 years. We've got a variety of providers. I remember when this provider list was 3 people. So you can see we've really grown to a broad variety all over the United States. If you look at the EHRs, we may have started with 2 or 3, but now all of the major EMR vendors are active. If you look on the payer side, from the association to several blue plans, Humana, United Healthcare, Cigna, all at this process. And then, of course, the vendors. So the vendor community, from everybody from people that support the implementation of technology to supporting the exchange of technology, and everything from the core of FHIR servers to care coordination. Many of the key vendors that are part of the ecosystem have been part of this system. And then with the industry partners, it's not just HL7. We've got HIMSS as one of our strategic partners, and NCQA as they do the variety of quality measures that are built off taking full advantage of these standards. In terms of what we were trying to do and the fact that we have matured, we're now working off the history of what we did with X12 standards and NCPDP standards, V2 standards, but now we're talking about APIs. And we're trying to, as part of this process, validate that these are consensus built. We're getting all the key stakeholders, not only the members, because if you're a paid member, you're involved in building the various use cases and prioritizing. But again, as part of the next steps in HL7, it goes into a work group where members of HL7 and other participants can be part of the dialogue, the reviews, the connectathon testing, and the building. And part of this is demonstrating with early adopters, as some of you have seen on this stage, with multi-care, regents, payers and providers actually using this technology in production and bringing back issues that go through the HL7 process to improve it. And also trying to figure out using and leveraging this technology to reduce costs and improve healthcare. In terms of, as this process has matured, what next? We're trying to make sure we have broader communities, because now we're getting involved in things like health equity, and many of you have heard the cancer moonshot that the White House is doing. So leveraging this work that's focused on value-based care in Da Vinci to other aspects of the technology. Also making sure we're ready to respond to these notice of proposed rulemaking. Uh, those of you who are familiar with policy would know a notice of proposed rulemaking is the first salvo in letting the industry know that a particular standard is likely to be named in a federal rule, where it goes from "we think you should look at this" to "you will look at it if you'd like to be part of and paid in a particular federal program." We are also looking at, for this year, are there new work streams that we can add? What are the things that could be done? What are we going to do with AI? Does AI play a role in developing the standards, making it easier to test the standards, that's all part and parcel of what comes with Da Vinci. In terms of to the left, what we're trying to do and work on, remittance use process, we're trying to make sure we can use a FHIR-based version of what used to be the 835 and X12, trying to make sure we're taking full advantage of the API technologies. We're looking at new use cases. Karuna is going to be talking about some of the regulations so you can get a sense of where the federal regulated use cases and where parts of Da Vinci are part of that. We're also learning through the work where we've got pilots and implementations, what are the enhancements? Again, the 80-20 rule is very much part of the HL7 process. We're not trying to solve the edge cases. We're not trying to solve things that happen once a month. We're trying to make sure the day-to-day work, the part that really affects care and administrative burden, get handled. But then we look at future enhancements, making sure the fundamentals work, and then also making sure implementation support. At HL7, you've got a lot of the top guns in technology, but in the real world of healthcare, it's got to work with a regional provider. It's got to work with a federally qualified health center. It's got to work with a AAA. It's got to work with community-based organizations. However, these are APIs. It can be on your laptop. It can be on your phone. Anything but using faxes. Let's at least try to kill faxes, and we'll see. And I also think it's going to be the next generation of the teenagers and the 20-year-olds. This is what they're used to. So as some of us retire, maybe some of the barriers to taking full advantage of this technology will go away also. In terms of the industry impact, in terms of what we're doing, it's events like this and opportunities for connect-a-thons, the various meetings where the industry can go to make people aware of the opportunity, make sure that there's implementation support. HL7 has got some new training programs, some new certifications. We're continuing to work and evangelize that this technology is beyond sitting on the shelf. It's more needing more people willing to be innovators and stepping up. As you can see, there's other events, Wheaties involved, Workgroup for Electronic Data Interchange, the VIVE conference, which is always exciting, the HIMSS conference that we're doing here, AAFP and CMS, all the stakeholders of healthcare are involved in trying to move this technology forward and taking advantage of the things we've done with Da Vinci. My last slide for this process to give you a sense of readiness. A lot of concerns were, well, what's the status of this implementation guide? About 2 years ago, one of our members realized, wait a minute, let's come up with a dashboard, something where it's easy to read. And then the other thing we realized with the variety of implementation guides, let's put them in, bolt them together. So for clinical data exchange, that's payer coverage decision support, clinical data exchange, payer data exchange, all of those are flavors of clinical data exchange. Under coverage, transparency, and burden, we've got a group of these, and each of them by color coding, if it's green, it means it's really mature. That's been used somewhere. It's beyond just a connect-a-thon. Active growth, meaning it's developing, but we really haven't gotten enough stakeholders to really adopt it. Least mature is going to be, well, we've got a use case. We've started building the IG. We've maybe done a connect-a-thon, but it really hasn't been through a STU1. Trial standard for use 1 means it's ready to go, but we're letting everybody know it's very likely to have an STU 2 or 3. So be an innovator, but know this will evolve and change. And we've also color-coded a little asterisk means it's referenced in or it's supported. A lot of federal regs will either say it's required or say we highly recommend you use it because not enough, and that's code for not enough of us have used it for them to comfortably name it as a federal regulation with all of the teeth that comes with it. We've got a symbol for aligned, and we've got some identification of where it is related to the functionality and where that functionality may have changed. And again, when you go on the website, you'll be able to click and do a deeper dive on all of these. Because of time, we won't go into it. But again, our experts are back at the kiosk if you want to explore a particular IG or particular area of expertise. And I'll turn it over to Karuna to give you an example of how a federal rule ties in with these standards. Karuna?
Thanks, Lenel. Do you mind if I get the clicker?
Oh, yep.
So as Lenel said, the government does a really good job of paying attention to the various accelerators and pulling from the work that they're doing to make policies happen. So Da Vinci is not the only accelerator. There's quite a few other ones like Gravity, FAST, which is Fire at Scale Task Force, Vulcan, Codex. Each of them have their market, their target goals as it relates to things like research, social determinants of health, etc. So as Lenel said, Da Vinci has been around for 6 or 7 years. HL7 came to the payer community and said, how do we start to engage payers with using HL7 standards? What can we do to bring that gap between providers, payers, vendors, government organizations, and agencies closer together? And so what they did was they worked with Da Vinci. They kept monitoring kind of the progression of these standards, as Lenel said, moving into this API world. And so we've come a long way from there. And, a few years ago with the Interop 1, they started off with the patient access API, and that was actually developed by a different group called Karen, Blue Button. So they're very focused on patient needs. And as the as the ecosystem has progressed, we've now had the opportunity to move to today's world. And so that's what we'll talk about a little bit in the next few minutes here. So the prior authorization final rule, I'm sure you've all been hearing about all week. It's top of mind, especially for payers. The payers that are impacted are the ones listed here: MA, Medicaid, CHIP, fee-for-service, etc. What we've realized as payers is this technology is in fact very effective, not just for compliance, but also for our business practices. And so as we have the opportunity to meet the requirements that we're now faced with that will be into effect in 2027, we have the opportunity to figure out how to scale these different technologies beyond just the required impacted payer groups and into our own commercial lines of business as well. So the proposed APIs that the government has put forth are the Patient Access API, a few updates there. The Provider Access API, so that'll open up the connections to the EHR health systems. Payer-to-payer API, so if you go from one payer to another, they should be able to pull your records and you shouldn't have to bring that on your own. And the Prior Authorization API, which has a narrow but deep focus in terms of the pain points that we all feel as patients and also as providers and payers. So what you can see here is CMS has done a great job of highlighting the actual standards that can bring the community together, many of which have been developed by Da Vinci. You'll see that they recommend implementation guides based on each of the APIs we just mentioned. They do not require them always, as Lenel pointed out in the dashboard, but they do highly recommend and suggest them. And the goal here is to not reinvent the wheel. That's what we do in Da Vinci. We bring folks together so we can align on things. As Lenel said, we can all play in the market and compete in an effective way, as opposed to coming up with proprietary methodologies that create unnecessary friction and barriers. What makes the policies different in today's world, in large part because of Da Vinci, are some of the various outcomes that you'll see as a result of the work that Da Vinci's done. So implementation success, Lenel mentioned that folks are actually using these implementation guides today. Those results are palpable, they're real, and they're significant. And they're largely focused on aligning on workflows and making that data exchange useful. Those barriers to clinical data are dropping as these tools are coming to scale, and there's various approaches beyond just the standards in terms of actually getting the technology to scale, whether that's through a network, point-to-point connections. So those barriers are significantly being dropped. You'll see that not only CMS, but also ONC are aligned, and so there's a coordinated effort to accelerate amongst the providers, payers, and vendors through formal certifications and regulations. And the larger goal of Da Vinci, as Lenel mentioned, is to support that shift to value-based care and reduce the burden.
Let me just add, actually, Karuna and I were both in a presentation prior to this where Multicare and was actually on stage because they've actually implemented this, and it was just amazing, the statistics where they had actually shown the actual percentage of time saved and hours and minutes reduced. So that's what we thought, but we now have examples from a large health system specifically pointing out this reduction of burden isn't just a theory, it actually is working to reduce physical time of staff in some amazing ways. And that's just the first round. So this is really working. It's not easy. You've got to align senior management, you've got to get the tech, and you got to do the workflow. But we now have examples in multiple facilities. This really does do what we thought it would do, which also means it's going to do even more as more of us use it, more of us figure out how to be creative with what we thought it would do, with you going, well, wait a minute, it does that for this particular part of my workflow, but I can reuse that same concept with the same technology. So I think the future is very bright, but I don't want to sugarcoat it. This is not easy, but it is consistent. And because it's a standard, that means you've got multiple resources, the industry standards, the technology, the consultants, the vendors, training that's available. We've got training and certifications for your members, so you can prove to your management, my team is not only trained, but they're certified at doing this. And as that keeps going, 2, 3 years from now, the opportunity to have more resources to help it. And again, creative vendors are going to find ways to make it easier for us to implement, but somebody's got to go first. And we now have the proof positive from several large health systems and large payers. It really does work.
Thanks, Lenel. So the next few slides here will show you how the implementation guides work together to actually solve some of the needs that are required by the API mandates. Here you have the prior authorization burden reduction group of implementation guides. So what you're seeing in each of the boxes are individual implementation guides that were shown on the dashboard that Lenel shared. The CDS hooks at the top are what enable alerts within the EHR. CRD at the top is the implementation guide where all of the policies are going to be documented. Is how you establish the relationship and the coverage of that patient. The next one, DTR, is where those policies are going to be documented, and then that prior authorization support is going to be the transaction for the prior authorization. If additional data is needed, there's another implementation guide called the Clinical Data Exchange to provide some of that supporting clinical documentation that's required. What you'll notice is a lot of, as Lenel mentioned, implementers are able to reduce the prior auth requests by 90%, knowing that 90% of them just get rejected right off the bat. And the rest of the implementation guides allow for that more granular analysis of whether prior authorization is required or not. You'll also see that the government has allowed for an X12 translation, understanding that payers and providers need to meet each other halfway. So while API technology does exist, this implementation setup does allow for translation between X12.
Let me just briefly add on the prior authorization support in that bundle that does exchange. One of the presentations yesterday, everybody's talking about AI. Well, one of the presentations was how AI was being used not to do denials, but AI was used for approvals. So when AI could look at the rules, look at the data, and give an approval, fine. Imagine how much workload. So now I just have to have someone assess and confirm as a, not all, but check just every once in a while. But for approvals, all that's being automated. And what's left are things where AI says, I'm not sure. And that goes to a human, goes to a medical director, the appropriate senior staff to review that. But that's a real world example where we take advantage of this tech, but use it carefully. At least in the example I heard yesterday, they weren't using that tool to deny. They were using that tool to go, oh, that's a slam dunk. Here's the rules, here's the data, you meet the rules, approve it. All that being done at the speed of light, that's a game changer. So now people can focus on the ones that might be a problem, the ones that might need more data, might need a phone call. Imagine the amount of work in prior auths that can go away as you merge this level of granular data with the capacity of AI to help move some of the low-hanging fruit off our people and on to more better results in getting that better care to our members and our patients sooner.
Thank you, Lenel. So I know we're running short on time here, but definitely wanted to highlight another very valuable implementation guide, especially to payers, Clinical Data Exchange. So you saw in the previous slide that Clinical Data Exchange is integrated into the prior auth workflow as needed, but it can also be used for quite a few other things, including supporting documentation for that prior auth, and then medical necessity, exchanging data between referring providers, and gathering that additional information for quality programs and risk adjustment. And those use cases are a little further down the line, but also part of the Da Vinci implementation guides. The provider data, or sorry, payer-to-payer data exchange provider acts in the content, the PDEX provider access API shown here. As you can see, looks complicated, but is meant to simplify the information that's shared through the provider. So just a little bit of what's important here in terms of needing a member attribution process, being able to integrate that claims history with the payer attribution rules, and some of the things that are required in the rules, like member opt-out for the folks that do not want to be able to share their data amongst payers and providers. Anything you want to add there, Lenel?
Well, just on the far right, I want to make sure you understand with bulk FHIR, if you're doing this at scale as a large provider and a large payer, one of the challenges is, well, I've got 100 people and they've got a large cohort of data. How is that going to work? Well, that's what bulk FHIR is. I give you that attribution list, I tell you what I need to get, and then it actually gets assembled by the provider. And the way that works is I keep pinging you. I've asked for this. Is it ready yet? Is it ready yet? When it's ready, I get the notice and then I go get it. So now we've not leaving a pipe open. We're not leaving that data exposed, but we're taking advantage of the new technology. And bulk FHIR allows us to move those large files that we need at scale. It actually works. So, welcome to the new world of being able to take full advantage of technology and get all this electronic data. And bulk FHIR allows us to work with those attributes with not having a real-time transaction hung up while you're trying to move that much data. Bulk FHIR is the way we take advantage of that.
Thank you. So in the PDEX payer-to-payer bulk API, Lenel mentioned a bit around being able to exchange large volumes of data. Again, you'll see a little bit of the important information as it relates to being able to match that request through member demographics, prior coverage, and consent. So some of these workflows, there's a lot to them, but the goal here is to create that technology that can make the interaction seamless, and the business and operational processes around that are a big part of this as well. Anything you want to add here, Lenel, related to payer-to-payer?
Nope, this is good. This even does a better picture on bulk data just so you can see that flow.
All right, and we'll finish off here with where you can find out more information about each of these implementation guides and everything that Da Vinci is working on today. There's quite a few resources for implementers. You can get involved in work groups related to the use cases on a regular basis. On the website, there's plenty of publicly available information. So if there's anything you can take away from today, it's you can get involved right away. We'll be at the kiosk, as Lenel mentioned, if you have any additional questions, but highly recommend working with your organizations to make them familiar with what's going on in the ecosystem and plug in a way that works for you. So anything you want to finish off?
My last tip is Google is your friend here, because trying to navigate all of this and all of the different accelerators, let me give you a clue. Just put in the Google search engine, I want Da Vinci PDEX. Guarantee on the first page you will find a link that will take you to the right page. So don't get hung up in I need to navigate the HL7 website. I need to navigate Confluence. Take a shortcut. Just type in what you're looking for and let Google bring you to that link. After you get used to navigating, you can do it, but I've been navigating this 5 years, and I just stopped trying to keep up with it, and I just go to Google and say, this is what I'm looking for, and I always get in the first page to the location I'm looking for. I say that because there's just so much information we have, and it's so available. Love it.
Pro tip. Thank you so much.